So guys, I have a knee MRI scan for us to look at and report. This is a 51-year-old male patient. He is obese and says he has chronic pain and edema on this left knee, and no matter what treatment he goes through, it just won't get any better. So let's see. This is major disease. This isn't really a very good looking scan, but this is such a severe disease that we can actually say a lot about this patient, about this case. So let's be patient. Let's look at the images. I have a bunch of sequences, even more sequence than normally needed to make a fine diagnosis, but let's see. I have these non-fat saturated sequences. This is a proton density, so we can assess morphology with much ease than a proton density with fat saturation. We also have coronal sequences. This is a T1 sequence, and we have proton density on all planes with fat saturation. This is a water weighted image, so we can readily see edema, joint effusion, and all kinds of fun lesions. So this is an axial, we have sagittal, and we also have coronal views. We also have this oblique view, which is directed towards assessing the anterior cruciate ligament, and we have a useless old age and gradient echo axial sequence, which we won't just pay any attention because it makes no sense to waste time on such sequence. So let's begin from the start. Just gonna fix this right here so you guys can see. So this is a sagittal PD with fat saturation. This is a coronal PD, and this is a very stubborn sequence. It just won't stay put, but it's okay. We can readily see that there is a slight dislocation, posterior dislocation of the femur compared to the normal position of the tibia. This feature is extremely present and common when we have complete anterior cruciate ligament tear. So I don't have the ACL anymore. It has been gone for quite some time. So there is this slight dislocation, which tells me I should look for the ligament and confirm it's not there. It's really not there. I can see right here the posterior cruciate ligament, which is right here. The anterior should go right here, but it really isn't there. So we have a ruptured anterior cruciate ligament. Also, we have major bone and cartilaginous disease. So the chondral covers of the joint are all gone or mostly gone. Right here, no cartilage. The joint spaces are narrowed, are reduced, and we have a bunch of osteophytes. Right there, large periarticular osteophytes all over the place. These three signs are the hallmark of osteoarthrosis. So this patient has advanced end-stage arthrosis of the knee on the patellofemoral space and on both femoral tibial compartments, especially on the medial compartment, which is the most common site of knee arthrosis in settings just like this. So we also have signs, very crude, intense signs of edema, of joint inflammation, which is called osteoarthritis. So we have arthrosis, which is the chronic disease, and we have an acute inflammatory disease, which is very painful, that is called osteoarthritis. So I have bone edema. I have right here a clear sign of a small joint effusion with very blurred and indistinct and heterogeneous margins, which tells me there is some kind of synovitis. So we have bone edema, we have synovitis, and we have a joint effusion. We also have a Baker's cyst right here. This tells me this joint effusion is quite old. This inflammation is quite old. We also have a edema of the inferior, the infrapatellar fat pad, and also of the superior suprapatellar fat pad, and a bit of the prefemoral fat pad right there, which are signs of chronic inflammation of synovitis. So this is all joint effusion and synovitis. If you guys look right here, there is a bright spot on the proximal extremity of the patellar tendon. If I get right here the axial view, and I scroll down until I reach the extremity of such tendon, I can readily confirm there is inflammation, a tendinitis, a proximal tendinitis of the patellar tendon right here. And I know you guys must be screaming on your chairs, pointing at the TV and the computer and the cell phone screens, complaining I haven't spoken about the meniscus. So the meniscus are all screwed up, they are destroyed, and they have been like that for a long time. I can see there are a bunch of meniscal tears, and much of the substance of the mass of such meniscus are gone. We can see there is extrusion of the body of the lateral meniscus right here. Also there are tears of the anterior and posterior horn. This is most probably a radial tear right here. We also have longitudinal tears and extrusion of the body of the lateral meniscus. And if we go to the medial meniscus, it's quite the same. This is diffuse disease. We have just a little bit of the posterior horn, a tiny portion of the body, and practically and almost nothing of the anterior horn, just the space where it should be. And of course, in the place where we should have meniscus, we have a complete destruction of the chondral surfaces, and we have bone against bone with sclerosis and edema right beside it. So this is arthrosis. We have both meniscus, chondral surfaces, and bone all destroyed, because this is a chronic major disease. We can also tell that the muscles are suffering for a long time, because I have hypertrophy, diffuse hypertrophy of the muscles, and we also have edema of the soft tissue adjacent all around the joint. So just to be sure, we have a chronic rupture of the anterior cruciate ligament. We have advanced end stage and severe arthrosis of the knee. We also have osteoarthritis, inflammation of the joint, right here, effusion, synovitis, edema, and a Baker's cyst. We have diffuse, almost complete ruptures, tears, and loss of substance of mass of both meniscus, lateral and medial. And we also have tendinitis of the patellar tendon tendinitis, inflammation of its proximal part. We have diffuse hypertrophy of the muscles and diffuse edema of soft tissues. So if you like this video, I'm pretty sure you're gonna like this one right here. Hit that like button and consider subscribing to the channel. And of course, I'll see you in the next video. So long.